We are now on chapter 16, the first video of chapter 16. I don't know if it really matters, but this is nursing management during the postpartum period.
Okay, chapter 16 is nursing management during postpartum. So the main goal during the immediate postpartum period is to prevent postpartum hemorrhage. The highest risk of postpartum hemorrhage will be that initial 2 hours after delivery. So after that initial 2 hours, then our goals, are still to prevent postpartum hemorrhage because it can still happen. But we also move into assisting the client's recovery, identifying things outside of the norm. So identifying deviations from the expected recovery process, providing comfort measures and pharmacological pain relief as needed, providing client education, lots of education about newborns and self-care, and providing baby-friendly activities to promote infant and family bonding. So typically that first 2 hours is obviously the most critical time for postpartum hemorrhage. During the first hour, we are going to do a postpartum assessment. A postpartum assessment would be vital signs, including temperature, and then a fundal check, which we'll show you in just a little bit. But we're going to assess that uterus to make sure that it's hard, that it's clamped down, and not bleeding. So we're going to do a fundal check and check the perineum and the blood flow that's coming out. So we're going to do that every 15 minutes for the first hour. During the second hour, we do it every 30 minutes. And then for the next 24 hours, we'll do it every 4 hours. Okay, I didn't look at this slide very well.
1 second. So, during the first hour, typical assessment in postpartum period. During the first hour, every 15 minutes, we see them every 15 minutes on the first hour. During the second hour, it's every 30 minutes. During the first 24 hours, every 4 hours. And then after is 24 hours every hour. Yeah.
It says after 24 hours, we do it every hour. That's not true. It's typically like every 8 hours.
Every 8 hours.
It depends on the hospital policy. Sometimes it's once per shift, but I'd say most hospitals about every 8 hours. So let's cross that out and do every 8 hours there. Here's just a little mnemonic for you, my favorite, just to help you remember. So this isn't necessarily in priority order, but the things that we want to do postpartum are support attachment. We want to facilitate attachment or bonding. We want to promote time with the newborn. Sometimes this means that we have to, kick some family members out. If you can figure out or get a feel that the patient really just wants to have some alone time with her baby, then we can promote that and help her kick some people out. We assess every 15 minutes for the first hour, then every 30 minutes for the next 2 hour, or for the next hour. We're going to assess vital signs, fundus, bladder function. We're going to massage the uterine fundus and apply tocolytics to maintain that tone and prevent hemorrhage. The medicine, the oxytocics or tocolytics, those are only if needed. Those aren't standard.
Okay, so pay attention to the term oxytocics. You may not have heard of this term before. It's a classification of drugs. So oxytocics. Oxytocics is an adjective that means hastening childbirth or inducing contractions or uterine smooth muscle. In labor, we give oxytocic drugs or Pitocin to hasten or induce contractions. In postpartum, we give oxytocic drugs, Pitocin, and methagreen and hematibate to promote uterine smooth muscle contractions, which promotes involution. Remember that term because, we don't want hemorrhage. So oxytocic drugs are used to induce labor, control postpartum bleeding, and assess fetal status in high-risk pregnancy contractions.
Breastfeeding may be started. We're going to assess lochia and our perineum. So that if there's an episiotomy or a laceration, we're going to assess that. And then we're going to encourage rest for both parents, encourage voiding to prevent bladder distension. We're going to educate the client to notify the nurse of any increased vaginal bleeding or a passage of clots. So let's go into specifics of what we're going to assess. So vital signs, we expect the temperature might be slightly elevated, but again, not more than like 100.4. 100.4 would be our max. After that, it's we're thinking more temperature, like more fever, infection type of thing. Our heart rate can go down a little bit. It's common to see heart rates 50 to 70 beats per minute. 40 is a little bit low. I don't think that's too common. But it is more common the first week after delivery to have a lower heart rate. This is puerperal bradycardia. It's expected finding and asthmatic. We don't do.
Okay, let me go through it. So temperature is a slight elevation during the first 24 hours. The pulse is like, there's some bradycardia, so lower. Respirations is normal, 16 to 20. Actually, it's a little bit higher. Isn't it 12 to 20? Yeah. So respirations are a little bit higher, but 16 to 20. Resting, right? Blood pressure within usual range. I think she was talking about it could be a little bit lower. And then pain goal between 0 to 2 on pain scale.
Don't do anything about it. We just change the alarm limits on the monitor. Respirations will be normal. 16 to 20 respirations per minute is expected. Blood pressure is usually within the normal range. It can be a little bit lower, but it's usually right there within the normal range. And then pain, we don't expect a ton of pain after delivery. That being said, there's a lot of factors that influence a patient's pain, and a lot of factors will influence how we manage the patient's pain. So ultimately, we want our patients to be comfortable enough that they can ambulate and participate in the care of their infant. So we want them medicated and going so they can walk around, so they can change diapers, so they can get up and get moving. This is going to vary per delivery, depends on how traumatic the vaginal delivery was, or if there was a cesarean delivery. So pain is obviously relative, but our ultimate goal is that their patients are up and moving and able to participate in the care of their baby. So you'll see this bubble. I feel like it's everywhere, but it's bubble. This one has bubble with 2 extra E's at the end. You'll see bubble he. You'll see bubble her. There's lots of variations. So let's just go off of this. And it's kind of all saying the same thing, just in different ways. But anyways, we want to assess the breasts. For the breast, we look at the size, contour, and engorgement. We don't necessarily do a full-on breast exam, right? Like touching the postpartum patient. But I'll ask them, how's breastfeeding going for you? I'll ask if they have any cracking on their nipples or any sores, any bleeding. This isn't too common those first few days in the hospital, but very common at home. If they're not breastfeeding, it's a good time to educate them on how to take care of their breast and how to decrease the amount of milk that comes in. It's also a great time to talk about lactation consultant that can come in and help with breastfeeding and the resources that are available outside of the hospital. For the uterus, we're looking at the height of the uterus. Remember, this is in relation to the umbilicus. So the fundus is the top of the uterus, and we want to know where the fundus is located in relation to the umbilicus and how firm the fundus is, and then if it's midline or not. So a normal assessment would say fundus firm at the U, or the U-1 or the U-2. And we're talking about that minus, it's those finger breaths. So one finger, width of a finger is about 1 centimeter. So we'll say U-2 means I can hold 2 fingers in between the umbilicus and the top of the uterus. It can also be +1, +2, and that would be above the umbilicus. But remember, we expect that will gradually go down. It really shouldn't increase. That could mean that it's filling up with clots or whatnot. So we do it.
Hold on. Physical assessment postpartum period. So we have breasts. We check for size, the contour, and the engorgement. Contour, the color, and the engorgement. The uterus, height of the fundus and firmness. The bladder, are they peeing? Are they voiding? Bladder emptying. Bowels, bowel sounds, distension. Lochia, the amount, color, and odor. Episiotomy and perineum, lacerations and hematoma. Extremities, are they, really excessively have fluid within them, and emotional status.
we monitor and look at it, and we really don't expect that it's going to increase in size. The other option would be my fundus will be off to the right. It won't be midline. It should be center, but if it's off to the right, that usually means that mom's bladder is full and it's displacing the uterus, and that could cause a postpartum hemorrhage. So we want to make sure that we empty that bladder. So again, a normal finding would be charted fundus firm at U, or wherever it is. It could be U minus 1, fundus firm at U, and then midline. So that would be your normal finding.
Okay, a distended bladder can cause uterine atony, weak, boggy uterus, which can lead to postpartum hemorrhage, and that is true.
If it varies from the normal, it would be like fundus is boggy, and a boggy fundus would be one that's like a picture, like a balloon that's been blown up, and then a week later it's kind of deflated a little bit. It's like that. You can feel the fundus, but it's not firm. So if a fundus is boggy, then we have to massage that uterus until it's firm. So that's its sole job. If it doesn't firm up, we call for help, and someone else can bring in the pharmacological interventions, or we put a catheter in. But really, you should just stay and massage that fundus until it's firm. This next slide here has a video of a fundal massage that I just wanted to show you. You can see how she has her hand here supporting the lower segment of the fundus. You put this right above the pubic bone, the symphysis pubis bone. So that kind of anchors it and secures the lower segment of the uterus. Because in theory, if you're pushing on that really hard, it could prolapse and come out the vagina. It's not common. I haven't seen it happen, but I've heard about it happening. So we want to anchor that and secure that lower segment of the uterus. And then we're going to assess and palpate. And I'll just show you the video here.
Fucking uterus. How hard are you fucking massaging it? Well, that's a mannequin. What the hell?
Oops, I don't want to do that. Sorry. So she said gentle massage, and you do a gentle massage, but if we have active bleeding, clots coming out, or it's just boggy, there's nothing gentle about it. It gets pretty firm. A gentle massage would be just for your general check, but if it is boggy and not firming up with a gentle massage, then we go into a deep massage, and it's almost like kneading bread. Like it doesn't feel good to the patient. It's not fun, but it's definitely necessary for the patient to prevent hemorrhage. The bladder, we want to ask them the last time they voided, or remind them that they need to empty the bladder, because they don't feel it as much and they're very distracted with loving their new baby. So not only can emptying the bladder lead to an infection, but an over-distended bladder can increase the patient's risk of hemorrhaging. So we don't want a lot of small voids. We want to really empty the bladder. So we will measure the first 2 voids after delivery to ensure that we're getting a good amount and emptying the bladder.
Okay. So how many voids should the nurse assess after delivery? Oh, shit. What did she say? How many voids should the nurse assess after delivery? Fuck, I don't know. 4? I mean, 3 sounds great. Oh, it is 2. How many voids should the nurse assess after delivery? And it's 2. Okay.
For bowels, we're going to listen for bowel sounds. They're going to be back to their normal spots. It's not uncommon that they'll be kind of hypoactive initially for a little bit. And it's also not uncommon that most patients will have a fear of having their first bowel movement. We talked about this in the last chapter. But it can cause a lot of anxiety and just a fear. I remember this is before I think I just started labor and delivery. I hadn't had any kids, and my best friend called me from the bathroom just bawling and so scared and afraid of the pain, and it was hurting, and it was kind of overwhelming. But anyways, if they've had any kind of trauma down there, especially like a 4th degree laceration or a or like a hematoma, any kind of excessive swelling, it's going to cause a lot of stress, and it could cause a lot of pain. So it's important that the patient's drinking a lot of fluids, has a stool softener that they're taking, and just, go from there. And then lochia, this is, again, the discharge that comes out, the bleeding that comes out after delivery. But we want to note the amount, the color, and the odor. Especially if there's clots, we want to know. This is kind of a good indicator of their blood loss, right? We call it quantitative blood loss, and now the nurses are weighing the pads to know exactly how much blood they're losing. But here is an example, maybe, of just how we define it, right? So scant lochia would just be a little bit, and remember, like if there's an ice pack on, that melted ice is going to dilute this, so it might look bigger, but if it's diluted blood, that kind of changes things. But we measure it in scant, small, moderate, and then heavy. So these are just kind of examples. And again, if we have clots, like really anything bigger, like a golf ball size or clot, you need to tell your nurse about that if you find that. Your nurse might scoff at you. It's relatively common to have golf ball size clots. But I just want them to know about it. Typically, we're thinking like baseball size, softball size clot, that's what we start to worry about. But if they're having golf ball size clots, I want them to know, and then especially if they have multiple of them, then you should for sure let your nurse know. Next here is episiotomy and perineum. That's the E in the bubble. So we're just going to check that perineum, make sure there's no new swelling. We're going to check for that RETA, so redness, ecchymosis, edema, drainage, and approximation. So if they have sutures repaired, we want to make sure that laceration is intact and not coming apart. And then hematomas can be slow to form. So we're going to be kind of checking to make sure that swelling isn't excessively increasing. We're going to check extremities. It's important to monitor for swelling or redness down in the legs. So that could indicate thrombosis or blood clot. And then we need to check for emotional status. We talked about this. We're going to talk about it again. But most patients will experience baby blues. Again, not so much in the hospital. It's kind of a happy time. Some do. You definitely walk into rooms and they just start crying. You're like, oh dear, what's going on? But it's important that we provide them education and resources for postpartum depression. It's important that we just normalize a little bit of a depression. And talk about it, that's an expected finding, and that it's okay, and it doesn't make them less of a mom, it doesn't make them not appreciate their baby, it's just a normal finding. But we do ultimately want to make sure that our other patient, the baby, is going home to a safe place, right? So that's kind of what we're looking at also, is to advocate for that baby.
Okay, foul-smelling lochia can indicate an infection. True.
So then this box here just kind of goes over, I think it's a good list of the factors that increase the woman's chance of having a complication. So risk factors for postpartum infection would be an operative procedure like forceps, a cesarean birth or vacuum, history of diabetes, prolonged labor. This would be anything more than 24 hours of active labor. If a mother's been ruptured for more than 18 hours, then usually we start antibiotics just for risk of infection. And then if she has GBS, we'll also we have those antibiotics going, but we also will increase her risk for postpartum infection. If we have an indwelling Foley catheter in for a long time, then this could cause just normal infection that you're probably seeing on the med-surg floors. But a lot of physicians want the catheter removed like 12 hours after a C-section. So we're trying hard to get away from having catheters in for longer than needed. If the patient is anemic with hemoglobin less than 10.5, That increases the risk for infection. If we did multiple vag exams, we try not to do too many vag exams. They are sterile, but there's always a risk when you introduce something foreign into the cervix or to the uterus, right? If there was a manual extraction of the placenta, if the doctor manually removed it, and then if the patient has a compromised immune system. And then risk factors for postpartum hemorrhage would be precipitous labor. This is labor from the first contraction to delivery of less than 3 hours. It sounds awesome, and in some ways it really is, but it's extra painful. Those 3 hours are definitely extra painful, and they have come with increased risk to mom. Uterine atony, this is when the uterus, the muscle is not clamping down and not constricting those vessels. And then, so this is when we do the fundal massage to help with that, to help kind of remind it, hey, this is what you're supposed to be doing. There's also medications that we can give to help with that. Placenta previa or placenta abruption. So we'll talk about these later in the semester, but previa is when the placenta covers the mom's cervix opening, and then abruption is when the placenta will tear off the side of the uterus too early. It's before delivery. So these are both very serious. The abruption is extreme, like an emergency. Previa, we can't deliver vaginally. So those are serious and can increase our risk for postpartum hemorrhage. An induction can increase the risk for postpartum hemorrhage because of all that oxytocin that we're using. Operative procedures, again, like the vacuum, forceps, cesarean birth, those all increase the risks of postpartum hemorrhage. Retained placental fragments. So this is important because remember how the placenta has those lobes. If any of those lobes get stuck inside, stay inside mom, the body will it can't contract down like it's normally. That uterus can't contract because it's got something inside of it that prevents it from contracting. So that will cause a postpartum hemorrhage. A prolonged third stage of labor. This is when we're delivering baby and placenta of more than let's just talk more. Let's simplify that. So prolonged third stage, meaning it took longer than 30 minutes for the placenta to be delivered. And then multiparity. So if I've had more than 3 babies, especially if they're closely spaced, this will increase the risk of postpartum hemorrhage. And then uterine overdistension. If I have a large infant or twins or triplets or polyhydramnios, excessive amniotic fluid, those things will cause overdistension also. We'll talk more about these complications and how to work with them later in the semester. Then your book also has this other table, or box 16.2, just danger signs. A fever or foul-smelling lochia, that would be a sign of infection. What's next here? Severe headaches, blurred vision, large blood clots. So large blood clots or bleeding that saturates a peripad in an hour. So excessive bleeding or large clots would indicate postpartum hemorrhage. Severe headaches and visual changes would indicate preeclampsia. Calf pain with dorsiflexion of the foot would indicate a DVT. Swelling, redness, or discharge at the episiotomy, epidural, or abdominal sites would represent poor healing, or it could be infection. Dysuria would be a UTI. Shortness of breath could be a blood clot in the lung, so pulmonary embolism. And then depression or mood swings would be kind of a psych issue.
Oh, okay. So because DVTs are more common in pregnancies, pulmonary embolisms can also be a common cause of death in postpartum women. PEs only occur in about 1 out of 7,000 births, but it accounts for 11% of maternal deaths, most of those happening after delivery. Oh, we're all done.